Hi, everyone. My name is Chris Sprague from Persimmon Health. I am a serial entrepreneur working on healthcare technology that helps more people access better quality of care. This podcast is for the movement of innovators, entrepreneurs, intrapreneurs, and thought leaders that are advancing the American healthcare system through digital health. In this podcast, we highlight real stories of innovators and enablers of digital health, their opportunities, challenges, and learnings for innovation. We'll cover topics such as startup building and fundraising, entrepreneurship, emerging technologies, and big ideas to transform healthcare. We invite you to participate in this community, share your stories, and accelerate the movement. Thank you. We have an awesome pod. Enjoy. I'm so excited because she is one of the true change agents within healthcare. Paula is a practicing vascular and general surgeon, physician entrepreneur, CEO, and founder of UBERDOC, designed to directly connect patients that need a specialist with the great specialist. We'll be talking a lot about equal access as a woman entrepreneur and surgeon, and as important as a patient that's trying to access quality care and the systemic roadblocks that make it hard to do. And of course, Paula is doing something about it with UBERDOC, and we'll learn about that too. Paula, you're an advocate for patient-centric care and women's health. I read two of your letters published in the Wall Street Journal and got the sense when we last spoke that you say a lot of things that many doctors are thinking, but not saying or don't know how to articulate. I hope to hear those too. I'm so happy to have you on the pod, Paula. As we dive in, can you please introduce yourself and what you do and how in the world do you do it all?
Well, first of all, I want to thank you for having me on your podcast. I think what you guys are doing are great, and the more voices that we have out there and the ways to communicate, I think, are really important, especially when it comes to healthcare. I'm a surgeon by trade. By birth, my dad was a surgeon, my brother's a surgeon, I'm married to a surgeon, two uncles. You kind of get the picture, it's the family business. So I also am passionate. I love what I do, and I love being a surgeon. I hate the system, and I thought maybe it was time to try to change it. So I fell into this as an entrepreneur. I have two kids. My youngest went off to college, and I said, now what do I do? Do I just keep doing surgery alone, or do I try to change it? And then I found I have a third child now, UBERDOC, and I became the CEO of a tech disruptive tech startup in my 50s. So it's been an interesting journey.
Yeah, that's amazing. And I would love to touch, as I mentioned, quite a bit on access and what's fair and right when it comes to healthcare. But as we're diving into that, I would love to know a little bit more about your journey, and either as an entrepreneur or a woman entrepreneur and physician. And were there any experiences that you had that you felt like were unfair, or you had to overcome to access the same things that, say, men in the industry or the positions don't have to deal with?
So it's interesting, as a surgeon in a family of surgeons, I was kind of used to going into an all-male world. You know, the only girl in your math class, you kind of all along, you kind of say, okay, I want to get there. But ultimately, in what I do as a doctor, women find a pathway. We may be the only ones in the room, but ultimately we hone our skills, we get our license to fly, and we get in the cockpit, right? Because we follow the rules. And it's a meritocracy pretty much. And as long as you do what you're supposed to do, you build your practice. That isn't to say that women in medicine, of course, are still, I think it's actually 70%. We're not quite on parity. But the point is that, you kind of know the path ahead of you. You know what the challenges are. And like many women in many fields, you find a path to success. When I started this journey as an entrepreneur, my first supporters were doctors. That was easy. They didn't see me as a woman physician. They saw me as a colleague. So I got a lot of support from physician investors. Physicians, I love them dearly, but they don't have enough zeros. So when you have to pitch your product to a bigger world and suddenly enter the business world, it was a completely different story. I mean, I pitched my product. I mean, who isn't going to like fall in love with, hey, you want to get direct access to a specialist, without waiting and pay a transparent price. Like everyone has a moment in their lives or their families' lives when they knew they couldn't get in and needed to get in. So people have a visceral response to UberDoc. But it was crickets. I mean, I didn't get any invitations back or any interest in terms of investment. And I'm like, what's going on here? Do I smell? What's the problem? So then it took, it was a Wall Street Journal article and an NPR report and a lot of research that came out a few years ago about the amount of money that gets women-founded companies only get about 2% of the money that's out there in venture capital. 2%. I was pretty floored by that statistic. I was not aware. I was completely naive. I was working with an attorney and also a PR firm that was very feminist. I called both of them and I said, excuse me, did you know this? And the response I got, I was a little unhappy with was, oh, we weren't aware. So if I told them, I said, well, if a patient came to me and said, Dr. Muto, that surgery you performed on me, did you know that it wasn't going to work? And if I said, why? I didn't know. They would say, well, Dr. Muto, you're not a very good doctor. Isn't it your job to know? Right? Isn't it your job to know? So I don't blame them. I don't think they were lying. I feel that many people don't ask the question and many people don't know. And that's been something that I'm very sensitive about in this journey and I'm quite outspoken about, is that once we find that path to success, we need to lay crumbs in the forest for the next woman, because there is no playbook on this. And I think it is terribly unfair. And, in other industries, when you think of like I think we talked about before about like when you audition for a symphony orchestra, you audition behind a screen and they don't know who's there, but they just choose the musician based on their ability to play. And when you get time on the web telescope, you just put it in, you put it in blindly without any name attached so that you get time because the idea is good. I think that investment probably needs to go into that. So it is unfair, but I think that's kind of the nature of investment.
Right. And you talk about leaving those breadcrumbs for the future generations of women entrepreneurs. What are some of those breadcrumbs or what are some of the advice that you would give to a woman entrepreneur today, now that you've gotten through to the other side and you're successful and
the other side. I don't know if there is another side, Chris. I think it's just
of course.
Because every time you get to the next level, there's another staircase, right? Another door you have to find. So, but I think that the expectation is important. It's so important to know, wow, someone else had the same experience. That was true even in like medicine, right? When women were complaining about harassment, people were quiet about it, right? You could only, because people didn't want to talk about it, because you were going to be perceived as weak if you complained. And the only way we could change it is when people felt comfortable to share their story. And so with women entrepreneurs, I think it's important to just say it, be truthful. It's not like, oh, it never happened to me. It's like, well, it's the statistic. You can't lie about 98% of the funds. Money doesn't lie. It may not be correct, but it doesn't, usually it tells the truth. So I think that is a big part of it is opening the communication and making women, feel comfortable to share and to question it, and not have the fear that if they do question it, they'll be kind of ostracized in that. I just think it's wrong, and and if we want young people to follow it in this path, they have to be given the same. They have to at least be given the clue at which door to knock on.
Right. Yeah, that makes a lot of sense. And then I guess backing up to, as a physician entrepreneur, I'm sure there's some things that you had to either learn on the business side or unlearn from the world of physicians in order to be successful. What are some of those things?
So, being a self-employed physician, first of all, I think most physicians are small business people. Even if you work in a big institution, the contract you make with your patients every day is the small business contract. So by nature, we're entrepreneurial. That's just the nature of medicine is that. So that being said, running a practice, is different than running a business. I mean, there's some things that are similar, taxes, payroll, and so forth. But there are other things, especially in the cadence of a practice versus a business. I mean, I work with life and death. You got to make your decisions quickly and move on. When I was building the platform, my tech people said I was the best entrepreneur they ever worked with, because as a surgeon, I made my decisions so quickly, right? I could do the agile method easily because it was just a decision tree. Risk, benefit, risk, benefit. A surgeon is like, that's what we do, is risk, benefit all day. But once the tech was built, and now you have to penetrate the marketplace, and you have marketing, and you have sales, and you have like investment, and it's suddenly a different timetable. And I'm very impatient. So I think that is what I had to learn, where when being doctoring, where everything, we're used to have that scalpel in our hand, getting things done quickly. And if they don't, we get to, get angry about it because we know we can, we're supposed to fix that. But in business, it's just not that way. It follows its own course, and you have to constantly be informed, and you have to be flexible, much more flexible than you were in medicine. You have to be able to kind of move in the direction where you think you're going to find those opportunities.
Right. Yeah, no, and that's commendable that you're able to make those quick product decisions, because a lot of people get hung up on that. But then also in our experience, in my experience when I was a first-time entrepreneur, the thing you learn the first time out of the gate is, okay, building it and launching that MVP is literally the start, right, of that next staircase, as you said. It's like, yeah,
I was good at that.
Yeah, and it doesn't matter how good what you created it is. People, you don't just build it and people come, right? You have to take something to market, you have to iterate for different markets, and you have to grow a business. Yeah,
you do, and that requires a team. You can have a pretty trim team if you have a vision and the right tech and so forth. But then once you move out of the box, you're now kind of out in the world. It's complicated. There's a lot of different directions to go. But yeah, I think that world of business just, again, follows a different type of structure than diagnosing and treating a patient.
Right. Yeah, and I think we'll get more into UBERDOC in a minute, but I love that you also start to solve that problem for physicians that come onto your platform, right? As in making that not just half the battle of getting onto a platform, but driving people to them to subscribe to the same needs and ideals. But yeah, no, I love learning about your journey. And before diving into the UBERDOC solution, I would love to set the stage and foundation for the problems that you see in our healthcare system. And in particular, I think it's important for any entrepreneur to understand how the business model works within healthcare and the trade-offs they support or don't support when they're adopting one. And just starting out, what are the different types of business models that exist within the healthcare industry?
So healthcare is, people like to say it's complicated, right? So we separate what I call medical care from healthcare. Doctors always say, well, what's so complicated? We trained for hundreds of years. We can treat, we train to treat something specifically, to do it well. So that's the practice of medicine. But healthcare is different. Healthcare is the industry around it to deliver the care. And that's where I think kind of the rubber hits the road. So in healthcare, when you talk about it, patients seeking care, people talk about payers, how does that equation work? A patient can walk into a doctor's office. What happens? Well, how do they get to the doctor's office? They have to have an insurance card. Our entire, healthcare system is based on a sort of a universal insurance model where everyone, by mandate, at least state by state now, not the federal mandate's not there anymore, needs to have access to health insurance or carry health insurance, or they'll get a penalty. So the concept of healthcare is like you use your insurance card. There's a third party in there that does the negotiation between the patient and the doctor, or the patient and the hospital. And that, we can talk about where all that came from, but it comes back to actually World War II. It goes back to World War II, and when Truman didn't want people to leave factories in the war. They put a wage freeze in. So rather than raising wages, they added benefits. And part of the benefits were, in fact, health benefits. And then after the war, if you were too old to work or you were too poor, you didn't have a job, they created Medicare and Medicaid. Truman and his wife were the first two recipients of Medicare. And then the employers paying for your health care just kind of came out of that. And then it continued to grow, and as things became more complicated, more expensive, and more business-minded, payers started to come into the marketplace, government subsidies continued, and then you basically have taken the equation of doctor-patient out of, we're no longer the buyer and the seller of the healthcare, we're the service provider, right? And the patient is, in fact, technically is paying, but not directly, right? And then you have this third party in between. So our healthcare model is not direct to buy. You don't buy your medicine, right? You don't buy your healthcare. You buy it through insurance or through a third party. And that system might have fit way back when doctors knew what was best for you, but we have a completely different healthcare delivery system now, very patient-centric and technologically diverse, where this system is no longer functioning.
Right. And so I think what you're talking about is the evolution of this fee-for-service model, but it's not really fee-for-service. It's fee-for-service with this middle entity in between called the insurance company.
Right. And when people talk about we don't like fee-for-service, we like this global payment because it's much easier to have a global payment in that model, right? Just have one size fits all. Here's your fee. That's it. But that doesn't require transparency. In fact, if you put transparency into that system, it takes it down. So we built this, no fee for service model over the years, which has actually constructed a complex paying scheme that allows for lots of middlemen and no oversight. And every day, like they just sued, CVS just got sued for data breaching and changing prices with PBMs, so there's a lot of opacity in the system. If there's a lot of opacity and there's a lot of money, what does it matter, right? You just go to the doctor, you swipe your insurance card, and you leave. But that's not what's happening. All the costs are now shifting directly onto the patient. So sort of like we can't afford the lack of transparency anymore in the system, because it's just that we can't control where all the money's going.
Can we unpack that a bit? Like, why can't it be transparent when there's an insurance company involved? And I've had this experience. Bimal, whom you've met, has had this experience where we go into a hospital and they just cannot answer how much is this procedure going to cost. Why is it so difficult to get that answer? It's frustrating.
So I guess my question is, and my dog is answering, but I guess my question is that, so the cost of care is finite, right? There is a cost to a procedure. There is a cost. But if you knew that cost, would you buy insurance to negotiate it?
I guess it just depends on the cost.
It depends.
But I've seen many bills where it just doesn't matter.
You just gave me the answer. It depends on the cost. So if I didn't tell you what that cost was, you would have no choice but to pay a premium.
Right.
So you see how like transparency. Why is it this way? I don't know. When I started practice, when I set my fee schedule, they said, okay, your fees are going to be set 2.5 times Medicare. I'm like, what? What does that mean? It's like, in other words, if your fee was $100, if you were going to get the Medicare allowable was $100 on something, your fee was $300. Like, well, why? I'm like, why? Why? I'm just asking. They're like, oh, because this is the way it is. This is the way it is. So all the time I thought this fantasy that there's some insurer out there that's going to pay me the big amount, because that was what they told us. Well, some insurers pay more, but no one really pays the fee that we set. And then I realized the fee that we set is because the insurance companies encourage us to do so, because then they can turn around and say, hey, look, she's really expensive. This procedure is going to cost you $500, but because you have insurance, we're going to take care of it, and we're going to bring that cost down to like $200, whatever. They're going to bring the price down. So that negotiation, I think, is part of why no one can give you the answer. And the people at the front end really don't know the answer. The best they can do is look at the fee schedule, and my charge master is going to give you that crazy price. If somebody looks up my charge master, they say, oh, she charges $5,000 for that. It's like, that's just this crazy fee that's way higher than we collect. Right. So it really is the opacity in the system is set so that insurance becomes more relevant. It's weird because when you get car insurance, I go to my mechanic, I have this wonderful place that fixes my car when I dent it, and they tell me what it's going to cost. Right. And I know my deductible, it's like,
it's straightforward.
And the system, when it gets layered, because now it's not just my surgery, it's my surgery but you need anesthesia, you need a pathologist, you need, there's other fees that are attached to it. So then and all those fees are finite as well and fairly routine, like they're fairly repetitive, give or take a few codes that you might add or subtract. Most of the time it falls in a range, in a bell curve.
Right. And so what about alternative business models within healthcare? So we've talked a lot about fee for service, but then there's alternatives that some people see as a panacea, some people don't, like value-based, outcome-based, direct pay, and so on. What do you view as the material differences between those business models?
So the value-based care is just another permutation, is another manifestation of managed care. Again, it was born out of the sense that, oh my gosh, the healthcare costs are so expensive because everyone's going to get unnecessary surgery, right? And going to specialists and so forth. So we're going to create this primary care model where everyone's going to go there first, right? And get all your stuff done and maybe never get a disease, right? And therefore be healthy for the rest of your life and never need any kind of procedure. So that was kind of came out of a world of public health people who think that, not medical people, public health people who think you can eradicate all disease, right? What in those models, value-based care is kind of part of that, where the primary care is the one who kind of manages your care, parcels out the money that they would spend on you, and if they saved money on you, theoretically if they kept you healthy or prevented you from getting a referral from to an orthopedic for that knee that bothers you, say, well, live with it or do this or do physical therapy, do something else, then they ostensibly would get some kind of refund or bonus back in their system. So I personally think that model can't exist today because that existed when patients didn't have access to the information they have now. Patients are much more well informed. They actually have informed consent. They are more than capable of authorizing their own care. And my patients watch my surgery on YouTube or someone else doing. They come in way more informed than they did. So I don't think patients really need to. They have other resources now that they can kind of figure out, gee, I've got something sticking in my eye. I can't see out of my eye. Maybe I need an eye doctor. I think maybe. And primary cares are overwhelmed with their own patients that need them to manage their complex medical disease. They do not need to be a rubber stamp bus station. Like here, stop here first to get your, to get your passport stamped before you get to go to the specialist, because that's just added waste for them as well, and why they get overwhelmed. So those value-based care models, managed care, it all stems from an assumption that specialty care is more expensive and that they're somehow going to limit access to that. Direct pay is a completely different model where, it started in the direct pay primary care world, where those primary cares could say, hey, forget it. I'm not a bus station. Okay, but I'm going to take care of you, and I'm going to limit my practice, and I'm going to spend time with you. I'm not going to limit you to 5 minutes. I'm going to be your doctor in the old-fashioned way where I'm here for you. I can answer your call, but in order to do that, I have to limit my panel. And so people would say, okay, your direct pay. So sometimes you can still use your Blue Cross or whatever, but you pay an extra concierge fee for that doctor to be available, and there's a direct pay component to it. So that is a very honest, accountable method of taking care of patients, because the doctor answers only to you, right? Not to a third party. And they can provide care that, rather than what the insurance is incentivizing or disincentivizing, they can feel free to offer the care for you that they do. The only problem is they need a network to provide the next step of care, right? That worked in the DPC world. And that's where UBERDOC comes in, because now there's specialists also that can take care of you for that same transparency. So that direct pay marketplace is emerging. We call it the DPO, is a very significant growth in employer-based models as well as individual.
Got it. And yeah, let's talk about value, because I mean, there's a lot wrapped up in even calling something value-based care, like, oh, hey, you're going to get more value, subscribe to whatever it is. And then also quality of care. And yet when you unpack it, it's actually defined as things like not being readmitted within 30 days or good survey scores. But really, in your experience, what, as a patient-centric advocate, what do patients care about in terms of feeling like they're getting value from their care?
So the three drivers of healthcare, the cost, knowing the cost, the speed at which you're seen, the wait time, and the quality. Of the three, the one that is always ranked third is quality, because patients assume quality, right? They assume quality. You don't choose your pilot, you choose your airline. And you expect that JetBlue is going to choose a qualified pilot, right? You don't know your pilot. But you choose the route and the price, right? That's what you do for the efficiency. So that is actually how patients behave, always. Now, outside of people looking for a second, third, fourth opinion on like some, rare cancer or melanoma or something, most people behave this way. If I tell you, Chris, you ask me, Paula, who's a good urologist or something, I say, oh, Chris, you got to go to Joe, doctor, whatever, and you go to try to make an appointment, and that doctor, whatever, is on vacation, but there's second doctor, Dr. Smith. So Dr. Jones is away, but Dr. Smith, and you're like, all right, fine, I can see that Dr. Jones tomorrow. Okay, I'll try that, and then that person becomes number one for you. Because when you go in, you're like, okay, this guy's great. Because most of us are on that bell curve. Most of us have done a lot of years and so forth. So again, the insurers and the people who are always trying to control where the dollar flows think that this quality can be measured. I can tell you, patients don't see it that way at all. Patients might go to have the best outcome, but didn't like the doctor because the waiting room, it was not clean, or the front end was mean. The person who answers the phone isn't nice. I can't stand that office, right? And at the same time, you can be like, I have patients that I've had complications with, and they keep coming back to me. It's like, wow, they still adore and love me, and I'm like, wow, they give me, they trust that I will take care of them, even when they've had complications. So it's really hard to predict those relationships. And like everything, when they choose a measure, they have to choose something to measure. So it's easy to measure readmission. It's easy to measure, the number of times, patients in an emergency room, right? But it's really hard to measure, the complexity of their anatomy that required the readmission, or the fact that the family situation. I have a patient now whose wife was just diagnosed with dementia. It's like, she's supposed to take care of him. Like, that's not happening. So those are all other factors that don't factor in. The social determinants of healthcare do not factor in to all of those quality measures, but you need something to measure. Right? And you can't measure how pretty is the incision, how much pain medicine the patient takes.
Got it. And in a direct pay model, how do you measure the value or predict or surface? So, for example, if I go to Yelp, I can see what everyone rated a restaurant, and I can choose to believe them or not. Usually, I read the reviews because I don't trust the overall ratings anymore, etc. Do you have like this synthesized value system? Because what I'm hearing is that value is very subjective, right, to the patient, and that people should have the choice, right, to prioritize what value they need from the health system or from a physician directly. Um, do you at UberDoc do anything to surface those criteria?
So UberDoc is a not a platform that anyone can join, first of
Okay.
all. Everybody on UberDoc is credentialed. They have to be a specialist, which includes, again, primary care physicians or specialists. Remember, pediatricians, internal
Yep.
medicine. Everyone has to be boarded in the specialty that they are listed in, and they have to be licensed in the state that they have a license, and they have to be credentialed at a hospital. So we those are pretty strong criteria
Yes.
to be on UberDoc. And then, of course, we do one step further. We make sure that somebody hasn't lost their license or hasn't been investigated or, has been in any kind of, criminal investigation. So we do that when they get on the platform. And that's important. Everything else, really, again, it's not the way people access care. I mean, you could go to the emergency room with appendicitis. You don't choose who's on. You just get, and you turn to the nurse and say, "Hey, Dr. Muto, can she do the job?" And the nurse is going to tell you, "Oh, don't worry, she's great." Or she's going to say, "Oh my God, get out of here! Better get out of here fast. Find someone else." Right? I mean, it's just not the
Right.
nature of the business. It's not healthcare is, medicine is just not that way. And it's not so. It is what we're trying to do with UberDoc is create a consumer-driven model where you get to choose your appointment, right?
Yes.
To a specialist. That's what we give you.
Right.
Whether or not, I can get you to the Italian restaurant. I can't tell you what you're going to order and whether you're going to like it, right? But I can get you to that place. I think we're more like Ticketmaster. I get you into the show, and then it's up to if you like the show or not. We don't have any control of that. But
Right.
again, ratings, it devalues what we do. And it's one of the
Right.
reasons why we call ourselves UberDoc, because we're not just an average doctor.
Yeah, and that's interesting because, I think the working assumption that people have is that the average consumer would prioritize quality of care over anything else, right? But the reality of it is, like you said, that's number three, and it's really going to be immediate access and convenience and things like that. And that's, by the way, how I access the health system as well, is along
And
those
empathy.
dimensions. Yeah, and
You have to
yes,
get along with your doctor.
right,
And when
right.
you don't meet your doctor, I had a patient the other day has been going to a specialist for close to 2 years and hasn't met the specialist. She's meeting her for the first time in October. I say, "Excuse me? How does that work?"
Oh my gosh.
It's on a very complex biologic. I'm like, how is that even possible?
Yeah,
She's
no,
working with her physician assistant or nurse practitioner. It's like, so we don't have what we call mid-levels on the platform. There are no, when you see an Uber doctors, you see the doctor. There are practices that work really closely with their PAs and nurse practitioners, but the doctor is present, or is,
right.
because we don't want to get into that sort of like world where you're not seeing what you're getting. These
Yes.
we and people, again, that's what people are, we wanted to keep it simple. What you see is what you get.
Right. Yeah, and I've had that experience too. I've had kind of ear problems all my life from cholesteatoma that kind of consistently recurs. And gosh, for the past 7 years, I've been in Portland, Oregon, and I do have to have these yearly checkups, and sometimes every 6 months I have to have a deeper one and a hearing test. And I've seen the actual specialist for 5 minutes, right? In those 7 years. And that was just to look at one of the tests that I'd done, one of the times of 3 visits a year. Yeah, so it's not like you don't get access to the specialists in general,
Right. So now,
even when you have a big need.
Chris, if you were paying for that, you probably are paying something for that.
Yep.
But say if you were paying completely for that, they may not opt to test your ears 3 times a year if they're not changing anything they're doing for you. Right? It changes the equation entirely, what you just said. Because if you have a third-party payer that is, the patient and the doctor are now not negotiating price. It's just, I'm telling you, if you have a third-party payer, then, you're like, okay, we'll just order another test. Or maybe the insurance company, very strangely, oftentimes say, well, you won't be able to order another prescription, say, for a hearing aid or something without another test. So it's strange where the insurance company think that they want to save you money, makes you get extra studies.
Right.
So this is where those third parties oftentimes can lead patients down and doctors down a path that they don't need to go down, that just increases the cost for everybody, and without the value. So that's about value, right? So how do you measure that? They're probably checking every box in that practice.
No, it's true, and I've considered getting a hearing aid, and the first on my list is Costco. Not going back to my provider to get that, just because of the experience.
Yeah, I mean, it's like, it's healthcare, as you're explaining, it's your medical care is personal, and that journey is personal and private, and the more someone else kind of tells you what to do, in today's world, I think that's where we run into problems, and I think people should very naturally like to take care of themselves as long as they're given the road signs, right, and given the opportunity to have choice to go somewhere. I think that's really important. But when they tell you have to do this, you got to have hearing tests 3 times a year. Well, what do I need that for? Well, you just have to.
Yeah. When we last spoke, you said something that struck a chord, that we've lost the core mission of medicine because we've become embroiled in the systems of healthcare. So I just wanted to unpack that a little bit. What is the core mission of medicine, and how have we gotten away from it?
So again, medicine is a science and an art to make you better, but it is also to deal with disease. You come to us with a problem, we solve that problem. We don't eradicate disease. We don't remove it. We just help make sure that it doesn't harm you or kill you. Right? We manage it. Cancer we don't cure. We just keep it in remission. We don't take away high blood pressure. We give you a medication to manage your high blood pressure. So I think that there is sort of this tendency to think that that medicine is sort of like, if you do it all correctly, you will eliminate disease. And I think, again, that gets back to the public health world. A lot of these MD, MPH people that are like policy leaders that sort of blur those lines between medicine and public health, because public health is all predicated on, yes, we're going to eliminate this and eliminate that and eliminate this through initiatives. So I think that, I like to think of healthcare and medicine as somewhat separate, and that as we move forward, our technologies, again, the doctors should be in control of the medical part of that equation.
Right.
And this is where we've lost control of that.
Yes. And I want to circle back to those physicians being in control of that in just a second. But we've talked a lot about the patient-centric view, but not as much about the physician and nurse side of the equation, and how the systems of healthcare, the business models of healthcare, are impacting people like your livelihoods and quality and missions. What is like the boots on the ground physician or nurses, staff's perspective on how you're being constrained, or what your life is like? So
medicine is driven by data, right? We take vital signs, we take information, we take your blood tests, we take your physical exam. We look and we obtain data. In the last 15 plus years, the data acquisition has gone beyond the needs to make a medical decision. It has included taking all sorts of information about you, your financial data, your social security, your credit score, all those other things, right? The insurance, and then put on top of that, people are trying to acquire more information. They want to know they want us to be data gatherers. So the electronic records have been really, when they were introduced, at first they were a wonderful repository of important information. You could get your x-ray information, you could get your blood test. And again, even when I was a resident, we had electronic records. And it was wonderful because you didn't have to go down to the medical records department and pull a chart out. You could sit in the ICU and suddenly pull up that person's op note from the last time they were there and know exactly what was wrong with them. So there was a tremendous efficiency in that. And that's important data that we use to make medical decisions. Over the course of the last decade or so, it's evolved into an invoice. It has become a billing interface. And we continually add more and more information that's no longer relevant to the patient outcome, but instead to some other reason, other purpose. And it's related to another purpose, and the other purpose has to do with whether it's gathering it to set actuarial tables for an insurance company, whether it's to set a premium, whether it's to unfortunately market your ICD-10, market your diagnosis to know oh, look, there's a population that is has this type of or highly obesity population. Oh, they're going to need a lot of diabetic medications for this zip code or something, right? There's all sorts of things that data now is leading to in the world of marketing and business. And so when a nurse, my nurse in my office, who's a brilliant nurse, she's the greatest nurse ever, and she's an ICU nurse for 50 years, she talks about the 75-minute hour. Okay, so when a nurse in the ICU is trying to take care of you, you're critically ill, they're hanging medications, they're talking to consultants, they're, turning the patient, they're, recording vitals. The way the whole system is structured, there's so much data that has to be entered into the electronic record, and in particular ways, it's impossible to do all of that and take care of the patient in 60 minutes per hour. So the tasks go beyond that. And I was talking to an informatic person yesterday who put in another workflow in our pre-op hold area that would require the doctors to electronically enter all of their pre-op antibiotics because they thought that was a safety issue. And I said, well, we have a conversation at the bedside with the doctor, the surgeon, the anesthesiologist, the nurse, the patient about that antibiotic, right? Now, you're going to get somebody who's remote, who's running late, who's just going to go on the computer for their 10 cases a day and pop in the same antibiotic just to make it more efficient. And it's you can't tell me that that's not going to lead to problems. Maybe somebody has a new allergy or it just didn't get recorded. Many times patients tell us, oh, I'm not allergic to anything, and they tell the nurse something differently. So the nurses and doctors are very, very frustrated over the amount of data that we have to acquire and the amount of time we spend away from the patient, and we have very little recourse. When we complain, they tell us we're not technologically savvy. You tell a surgeon who uses new technology every day, well, you guys aren't tech savvy. So now when they tell me that yesterday, Dr. Muto, you're not tech savvy, I raised my hand, I said, I actually created a tech platform. So you can't say that to me anymore. But this is the problem. So doctors and nurses are very, very frustrated, and it has to do with data, all of the data acquisition and the time spent away from patient care.
Got it. And is it at that breaking point? Because I've seen so many different stories, in particular through the pandemic, of physician burnout, of nurse burnout, of people feeling overworked and underappreciated. Where are we at today?
Oh, huge. Well, the pandemic just kind of unveiled a lot of weaknesses in our system to begin with. The nurses were asked to work these crazy shifts, and then oftentimes they were replaced or substituted by traveling nurses that came and made more money than they made. So nurses actually quit and started to travel and have their own hospitals. And so you had tremendous hours that were expected. It was a really pandemic emotionally was difficult because so many patients were isolated from their families. The nurses at the bedside became their family. So there's a huge emotional toll. I would say PTSD for sure for people that were in those ICUs at the height of the pandemic. It was, I think coming out of all of that, you saw big retirements. You saw lots of people who said, hey, I'm done with medicine. A lot of physician colleagues of mine have decided that's it. The pandemic was kind of a press and pause for most doctors, where you didn't have control of what was happening. You obviously didn't see as many patients as you used to see because everything kind of stopped. And when you came out of that, many doctors said, hey, I was only working 3 days a week during the pandemic. I think I'm going to continue to work 3 days a week. So a lot of doctors came back kind of half time, and other doctors who said, I'm probably going to retire because they saw it differently. And so we have a huge exodus in medicine on both the nursing and doctoring and staff, medical assistants, front ends, receptionists. There's a huge exodus from healthcare right now.
Gosh, and who are the right people to fix this? Last time you mentioned something that made sense, that, hey, it's the people who know the jobs to be done the best, that, and know how the system works today, that may be best to fix it. And you mentioned physicians who run for office. So I'm wondering, why is it important for physicians to run for office, and what excites you about this movement?
So in general, I think physicians need to step up to the plate and fix medicine and subsequently healthcare. We've been pretty much sidelined during all of this. So my fellow physician entrepreneurs, I give them a great deal of credit. The people who attend Innovator MD, it is just, unbelievably talented, brilliant people all coming together, all physicians who have seen solutions. So I think doctors, are entrepreneurial, as we said, by nature. We're problem solvers by nature. One of the things that I learned to appreciate is that, here I was in my 50s taking on a task, taking on financial risk, taking on personal risk to kind of devote time and energy into a startup to change the world, right, to fix something. Running for office is very similar for a lot of physicians, and I didn't realize that we have doctors around this country who were very successful physicians. Many of them are still in practice, and they were like me. They hit their 50s, and they said, I want to fix something. How do I fix it? I complain all the time, we need more doctors in Washington. That's kind of how the vets worked, right? You have a lot of veterans, and a lot of bad things happen to veterans, and veterans started to run for office. And then now you have members of Congress who are vets. So guess what? They get it. Right? So when you're talking about defense bills, and they're talking about appropriation for like military combat or what, you got people that are sitting there who can raise their hand and say, you know what, I've been there, and I think that is so important. We need to have physicians and nurses, pharmacists, people in healthcare, frontline people going into office. I think is so important. Because again, very much like me and my fellow physician entrepreneurs, they're doing so. They're entrepreneurs, and they're running for office. They're raising money, just like they're pitching. They're raising money. They're doing exactly what a lot of us are doing. And then when they get there, they have to make a change. And it's really good to have ears in Washington who've been in operating rooms, who've taken care of patients, who understand the fundamentals of medicine. When we have doctors that are in office or in policy, we have a lot of doctor, again, a lot of MPH, MDs, people who, like major architects of Obamacare, they were not practicing. They weren't in front of people. And are in the trenches every day. So you didn't get a sense that what they constructed made any sense. Like the electronic record implementation, if anyone had ever been practicing, would realize it was completely opposite of the workflow of a hospital setting or a clinic setting. And yet, so somewhere along the way, when they were designing that, the user experience, they didn't think of the end user. So to use tech terms, we have to design a system or policy, and we have to think of our end users. And the end users in healthcare are patients and doctors. Right. Those are the ultimate end users, right?
Yep. And yet the biggest system in healthcare, is designed for the middlemen. Yeah.
It's just designed, we think about the insurers and we think of the payers, the employers.
Right.
We do not actually put the doctors and patients into that equation.
Right. Gosh, makes a ton of sense. And now you are making a difference with UBERDOC. You've invented something awesome that doesn't necessarily address all the problems of healthcare, but does wisely choose which problems it's going to deal with and allows patients and physicians to sidestep parts of the system if they both agree. And I think that's great. So what is UBERDOC and what made you start it?
So UBERDOC is a platform. It's a network of direct pay specialists where a patient can find a doctor who is nearby and available and make an appointment, go and see them in person or via telemedicine, and pay a transparent price through a health savings account or credit card. So it doesn't require a phone call, a referral. It's again to try to bring care local. Like way back when I was writing, I still write angry letters, but when I started writing angry letters, I was reading an article about a woman in New York City who twists her ankle. Okay, she goes to the walk-in or the ER wraps her up and then gives her a referral. She goes to her primary dutifully, who then promptly refers her to an orthopedic in Stamford, Connecticut. Now, she doesn't have transportation. She has she's on crutches.
Right.
She lives in Manhattan. She Googles orthopedic surgeons near me and finds about 15 of them. She picks up the phone, makes an appointment, goes in, pays cash, and she said, "Why can't it be that way?" And that was my aha moment. I'm like, absolutely. Why can't it be that way, right? Why can't it? What makes it not that way? And then I looked at it and I said, there's nothing that makes it not. As long as there's a doctor who's willing to put a seat aside and take a cash pay patient without a phone call, through an appointment scheduler, and as long as there's a patient who's willing to pay the transparent price for the visit, it can be that way. And so that's where UBERDOC was born.
That makes sense. Are there any rules for doctors that are enforced by their employer? So the health system they work for example, in some technology companies, they try to have these that are considered generally unenforceable contract terms around moonlighting, working on something during your spare time, or intellectual property that you create while employed at that company is all under the company that you work for. Do doctors have to deal with that if they want to also be on UBERDOC? Or is it
UBERDOC is just an appointment maker, right? So any doctor anywhere can be. Now, naturally, the independent doctors can join easily. They're like, oh, sure. It doesn't cost anything for doctors to join. They can join in minutes, and they can post their appointment slot. So there you go. And it's easy. You say, okay, I see my patients every Tuesday morning at 9 a.m. So at 8:45, there's a slot. It's like a ticket, right? It's like I perform 8 shows a week, and I'm going to put a house seat aside, for my Wednesday matinee, whatever. That's how it works. So now doctors who are employed by big groups or institutions, they have to kind of like push it through they have to push it through the bureaucracy, right? They say, okay, great, I'm going to post an appointment slot, but then who gets the payment? It's easy when you own your practice because it's your bank account. But when it is when you're owned by someone else, that's where contracts come in, where like you can't practice medicine. If you're going to get paid to see a patient, the institution has to get the payment. And most doctors are perfectly fine with that. It's just that when they go to their office manager and say, do you have the bank account number to put in? The office manager goes, oh my God, we got to go up the channel. We talk to the director, then the director goes to this, and the director, then all of a sudden it goes all the way up to like the CFO. Now, no one really has an objection to UBERDOC. I started with all the boardrooms in Boston and got, very good responses and standing ovations, right? Because who wouldn't take a patient for cash? I mean, come on. It's like, why would you turn business away, right? But their bureaucracy and the way institutions work, it's like a 10-year sales cycle. I mean, it's terrible. It's right there, and then of course COVID hit, so it's like, we can't do anything until after COVID, right? We're dealing with COVID now. So COVID became the great excuse. So now, of course, access is a huge issue. Those receptionists are not there answering phones. And no one's going to work in a cubicle with no ventilation for $10 an hour anymore. You can outsource it to some degree, but patients really want the convenience. They just want to make an appointment. They don't want to put aside a whole day waiting for someone to call them back. It just doesn't make sense. So we're approaching a lot of those institutions, say, let's just make your appointments for you. Just put a few seats for again, so we're system agnostic. We can work with anybody. My goal is a seat in every waiting room, whether it's a big institution or whether it's a rural practice.
And how are the health systems responding to you as their scheduling system?
So again, the people were always really excited about the model. My biggest fans are CFOs, because the chief financial officers see the bottom line, and control the patient access. But then as it filters through the layers, again, it's one of those things where it's just easier for us to just go right to the doctors, and I kind of feel like it has to come from the doctors. We have some doctors at big systems; they're just on UBERDOC on their own. Because if they wait for the system to sign off on it, took 6 months with partners, our biggest, in their legal team, to try to tear it apart, and then they realized they really couldn't tear it apart. It's just a health savings account or a credit card.
Yeah, gosh. Yeah, it's so interesting how, but behind it feels even now, just because so many other industries have moved beyond that, right? Like if I want a reservation at a restaurant, I can go to Yelp or I can go to OpenTable. I don't have to call the restaurant anymore. If I want food delivered to me, there's a number, including Uber Eats, right, that I can call and get food delivered to me. And this whole concept, or of course Expedia and travel companies that do get to reserve slots, and they added so much efficiency and then choice, right, to the system and transparency to the system for the end consumer, right. And yet the health care system has not moved there.
At the very beginning of this, I was in contact with Arun Sundarazian, who wrote the book called The Sharing Economy. So he's an economist out of NYU, and it was about like the Lyft and Uber and Airbnb and how they came about. And the concept was that, you have two versions of economics. You have these hierarchical corporate models, and you have peer-to-peer transactions. So you think that Airbnb, Lyft are disruptive because they're in fact a peer-to-peer marketplace. Like Amazon is a marketplace, peer-to-peer, right? People are buying and selling on it, peer-to-peer. But in fact, a corporate model is the disruptor. Because 90+% of business transactions in the world are really peer-to-peer. They're your local business person, your cobbler making a shoe or a baker making bread, right? I mean, most of these are peer-to-peer transactions. The corporate model is actually the disruptor. So when you think about medicine is a pure peer-to-peer transaction, always. Doctor-patient, in a hospital, nurse, it's like it is a peer-to-peer. But we've tried to make it a corporate model. And those top-down approaches, again, work in public health, like everyone should wear a seatbelt, nobody should smoke in public places. That's a nice top-down initiative. Vaccination, perfect example. But that's not medicine. Medicine is not top-down. Medicine is like, you have this particular disease. There are 5 choices for me to treat it. We're going to choose the one that is probably, what we think is going to be best for you based on what we know. So it's a peer-to-peer transaction. So from an economic model, that's how it's different.
Right, got it. And what's still missing from direct pay models? So, for example, now we have UBERDOC, which connects the patients who need an expert with someone qualified that is willing to take money directly from them. Sounds awesome. So you've solved that networking, matching problem. But what else is needed in terms of technology tools, policy, market readiness to really make this take off?
What happens with the next step? You see that orthopedic and they say, okay, we want to do an injection. So now the orthopedic, or an x-ray, the orthopedic has to have a price for the x-ray. And if they don't do their own x-ray, they have to work with imaging, and that's where green imaging comes in. These amazing companies that's really breaking the mold to repurpose, to optimize existing equipment and staff and navigate patients into those spots for a transparent price. It's a brilliant model.
Right.
So then, of course, you need to get a prescription and you want to make sure that prescription is transparent. You may need to go to surgery, but you want to make sure that that price may be transparent. So the moonshot for UBERDOC is we start with the first step in the doctor's office, but then after that, if you want to proceed through a transparent model, there should be transparency. Doesn't mean that you set the price, because the prices are going to vary from like Texas to Oklahoma to Maine to New England, right? I mean, it's always, you can't predict, but you can set the transparency. And so ultimately, you want to make sure that the next steps are always going to be important. UBERDOC is about that first step, because I believe that many things can be solved in that first step. You go to an expert who's seen it a million times, you're going to get the answer. And I think that we have spent way too long assuming, again, that specialists are more expensive. They're not. That they, will order out a lot of tests you don't need. Probably not. I mean, it's like, good behavior comes from good healthcare. Good medicine is good behavior. And like my dad said, just take good care of the patient and you'll be financially successful. So I think that, like you said, those next steps, what comes next, what's the obstacle? In terms of just UBERDOC getting patients to change their behavior, to look for direct pay models. And that's really on us, doctors, to show that you can trust us, that we are going to give you a transparent price. And there's legislation about surprise bills. There's more consumer protections coming down the line. I think 5-6 years ago, it was a lot harder to convince people. Now everybody's deductible is high enough. Everyone's paying, no matter how great your insurance is. So I think now it's an easier sell, and to get that patient behavior to change and to get them rewarded, right? If cashback rewards, if you pay cash for your care, you should pay less of a premium.
Yeah, no, I think it's fascinating, and how quickly it seems to be turning, and at least traction in that direction. I know I was listening to an Andreessen Horowitz podcast maybe a year and a half ago, where they were talking about LASIK eye surgery, and in the malls, accessible, direct pay, get the insurance company out, and this is what consumers want, even for that level of specialization. So I think it's awesome that you're supporting that at that next step. And yeah, I know I hear you that accessing the rest of what care could mean, whether that's more tests or procedures, etc., is an important for the completionist aspect of having this alternate system. But I think what you have in terms of, hey, direct primary care plus these specialists are probably 80-90% of what you actually need or want, makes a lot of sense.
Right. I mean, and a lot of times you're going to solve it in an office. You're going to solve it. It's, again, technology's brought us so far where we do outpatient knee replacements, for goodness sakes. I operate in my office this morning. It's like the stuff I used to do in the OR, I can do in the office. And many times I don't operate at all. I just give you a pill and it takes away your arterial disease. So there's so much in technology right now that has changed the delivery of healthcare. The delivery of medicine, I should say, medical care, that the healthcare system has to adopt to medicine.
Right. And the system is never going to adapt as fast as a market, open market.
You are 100% right. And so knowing that it's the patient that is the one in charge, knowing that it's that we don't live in a we know what's best for you world anymore, right? We respect autonomy and choice. And in that environment, then, of course, yes, the patient is the consumer, the patient drives it. And the patient should be rewarded for good behavior. The patient should get the bonus if they don't utilize. Why are you giving it to your doctor? Give it to your patient. Give it to the patient. Give it to the patient for their health care the next year.
Yep. Yeah. Okay, I'd love to talk about the growth of UBERDOC, and in particular, scaling it. Because UBERDOC is essentially a marketplace, and marketplaces are notoriously some of the hardest problems to solve, because you have this supply and demand that somehow need to be built in lockstep, or no one's going to find value from anybody on either side. So you need doctors for patients to come, you need patients for doctors to come. How did you solve this chicken and egg problem?
So when we first built the platform, we put our first 45 doctors on. I'm like, yay, we're done, right? And then we had one like TV spot, like they did a story on us on the local news, and the platform like immediately like we got patients. I'm like, okay, that was my test. I knew it was going to work. Now we can't be on TV every day, and that was really expensive. Like with everything, when we started to drive more, we have doctor patient, like to sell to the patient, you need a lot of inventory. You're absolutely right. You can't like open up for Black Friday until you have enough inventory on the shelf. So we concentrated really on that inventory, on those doctors. And we started with just 6 core surgical specialties and expanded it rather rapidly, and then embraced our DPC colleagues in, and that really exploded the platform. We pulled away any subscription. We made sure the doctors could join without much friction. And then we just went across the country, door to door. I went beyond my doctor's lounge and beyond my state and beyond my specialty. And I couldn't find a naysayer. So it was really hand-to-hand combat, basically. And now, we have a robust marketing campaign and we've built the largest network now in the country of direct pay specialists. And it was really solidly built because it was built literally by hand, right?
Right.
And we're very proud of that network. Now on the patient side, we go to aggregators. We have a contract with the state of Massachusetts. We have working with employers, medical cost share groups to be TPAs so that they need direct pay specialists. They're using our network. But ultimately, this is a direct-to-consumer model, and I would love to get right to the patients. And how do you do that? This podcast there. How do you use UBERDOC, right? Because I used to think it's the best kept secret, but it shouldn't be a secret now. And so we encourage our doctors to market to their patients and use it for their own appointment making. I do think it's an easy concept. I don't think it's hard for patients to figure it out. It's just another thing that they would have available to them. It's situational. You don't have to use it every day, but when you need it, it's there. So I think that, like I said, getting it to the consumer, as you said, that marketplace, I don't think it's an issue of changing behavior so much as knowing that it's there.
Right. Because awareness that there is this better option. Yeah.
Yeah,
absolutely.
It's just it's like people go to urgent cares all the time. Like their behavior right now is to find something convenient, accessible, and affordable. So that behavior is already there for medicine, right? So we're just saying instead of, it's your eye, instead of going to the walk-in, get the referral to your primary and get to the eye doctor, just go to the eye doctor direct.
Yep, makes sense. And is there a geographic component to at least the early days of your growth? Like, okay, we're going to focus on Massachusetts first, or this part of Massachusetts. I know there was a offering component, like Amazon started with shoes, or Zappos started with shoes, Amazon started with books, and were there other dimensions?
We started, with our 6 core surgical specialties, and orthopedics, urology, gynecology, general surgery, vascular, and ENT, and in Massachusetts because that's where I live, and those are my colleagues, those are my connections. Rapidly, we got people interested in other places, and then we started to just. Everyone said just concentrate in one area with one specialty. Well, that's just not the way it worked. I mean, it's like that's easy to say, but so ultimately, we started to get we wherever we could get access, we started to the word spread. Like in Florida, it spread really quickly, and we got a lot of doctors in Florida, California, where our investors were. We now have a lot in Texas, Ohio, and so next thing you know, it's like, it'd be great if we could just confine it to one area. So we did start playing with zip codes and drive traffic to certain zip codes. Psychiatry, for example, was always an important one, because a lot of people don't want to use their insurance to see a psychiatrist, and so we concentrated on one specialty in one particular area. We used Google AdWords and so forth, and we were able to prove the model. Now to sustain it on a scale, it's costly, and you could put a lot of money into Google AdWords and all that. So we kind of tested it in these areas, and again, the model worked. So then, essentially, we said, we scaled stuff back just because, going direct to consumer, we kind of had that. We had the playbook for that. But to do it right, you have to have more funding. So we pulled it back and just went straight organic growth. So now we have great organic growth on our platform. Like anything, how do you bring anything to a consumer market today? You can spend tons of money on ads and Instagram and all this stuff, and the ROI on that stuff is so high.
Right. What's the biggest challenge left for you to scale UBERDOC?
It's really the patients. It's the patients. Letting the patients know that we have 20,000 appointments waiting for them, right? And that we're here for them. And when patients don't find what they're looking for, tell us. If an employer tells us, hey, my employees need to be covered in this area, we'll find those doctors for you. We'll invite them onto the platform. We want to be that. We want to be that networkless, access to care, because many times you have people now living in Austin, Texas, but working in New York. So are they supposed to fly to New York to get their medical care? How are you going to control that cost? How are you going to, in a modern workforce, how are you going to cover them?
Yes, yeah. And it's along a lot of these trends that we've been seeing recently of decentralization. So in cryptocurrency and blockchain, all about decentralization. Web 3.0 is the same thing, but really scaling the access and the responsibility out to the people themselves rather than an entity controlling things. And it really
healthcare is the most personal choice in your life.
Right.
That's right. That's the very last thing you need to. You don't talk to your banker about it. But you talk to your insurer. You talk to your employer about your health. They shouldn't know anything about your health. That's not their business.
Yep. Okay, let me ask you some questions about your learnings. And are there any of the biggest learnings that you want to share? For example, the biggest mistake or misconception you had, or the best decision that you took, or advice that you think is just printed off this UBERDOC assembly line for digital health entrepreneurs because, it's something you glean by experiencing?
So I think that on the mistake side, don't underestimate lawyers' rates and time. I was taken aback on that. We're having a chat. I'm just asking you a question. It's like, oh wait, there's a dollar bill attached to that. So so the attorney's fees, the whole, there's the transactional people out there that it's part of the business world. And my only mistake is not doing my homework on that and knowing ahead of time. And I think that's really important for entrepreneurs to know and appreciate. The best decision I think I took was when I pulled the subscription. When we saw the interest among the DPC doctors, and they really were great supporters of our model from early on, saying, do this, build it, keep it going. That was a really important decision, even though it took away the attraction of a SaaS model, a subscription model, and it gave us a much longer runway because you need to to build revenue off a transactional model. As you say, building that marketplace first, you have to, you take a sacrifice on that. But I think it was well worth it because it expands. It makes us infinitely scalable, which is what makes us unique in the marketplace. And as far as advice to people, I always say just be patient, right? You try to rush things. You try to think it's going to happen tomorrow. You have to remember that the forecast it's a long play, right? It's a marathon, not a sprint. And even though you do get to the next level, like you say, the MVP is launched. It's just the beginning. It's not, every time you turn the corner, you think, oh, I'm there. But you're not. But the exciting thing is every corner you turn, you see more possibilities. And I think the difference between a success is that the more possibilities you have that don't stray from your initial mission, I think is key. Right? So many people I say, oh, I pivoted. And they pivoted entirely away from their idea. Right? they just I had one person say, you should really think about adding insurance into your equation. I'm like, But that would really take away the whole purpose of UBERDOC, right?
Yes, exactly. And that's what's happening in the DeFi world, decentralized finance world, where we had this thing called cryptocurrency that's completely decentralized. And the first thing people tried to do, of course, with greed in mind, is create these centralized banks that would take people's money and loan out different instruments, and now they're all collapsing, right? So yeah, don't recreate the system
Well,
you're
it's like
trying
the
to
Uber
fix.
drivers that want benefits. It's like the whole purpose of driving for Uber is you work for yourself, right? You know, yeah, those business models, again, when you take advice from people and investors, but you try not to pivot away from your core mission. I think the ones that have been successful have always kept to that mission. And be flexible. You add, you nuance it, but you don't actually ever change the purpose.
Right. Okay, I want to know just two more questions. Paula's big ideas around healthcare. And one of them is just expanding on something that you shared with me. And I hear different variations of this statistic, but they're always eye-opening. Is that you mentioned that 73% of healthcare expenses go to the middlemen, right? Only 27% go to the actual people that are delivering care. Can you, for our audience, explain the math here? And the numbers I've heard are both just a little bit above or a little bit below that. So absolutely, that seems accurate. And many people don't understand that math. How could that possibly be? And of course, direct pay is a direct answer to taking out this middleman. But why is it 73%?
Well, because the management, again, healthcare is costly, medicine is less costly. As we've moved away from expensive places, like think of cancer therapy, right? You used to get admitted to the hospital, get your induction therapy, and then go home. It cost all those days in the hospital, all those people involved. Now you get a pill, right? That's made for you, and you take it at home. So the cost of the pill is one thing, but then the cost of delivery of that care is much lower, right? We used to admit patients to the hospital before surgery, keep them in the hospital after surgery till their staples came out, went home. Now patients go home immediately, right? They don't get admitted to the hospital. So now the post-op care is really, the family has to do that, right? That's where social determinants of health come in. But the cost of that delivery, the cost of that system has come down. So that's why the pendulum kind of shifted, because that 73%, think of it as that 73% being that kind of clunky, keep the lights on this big building, right? Say you have a big building, but all of your employees are now remote. But the big building still requires, a company is still paying the electric bill and the gas bill and the cleaning service, right? To keep the big building going, but your employees are at home. So only 27% of that of your cost is, you only need to spend 27%. The rest of that 73% is putting into a system that you don't need anymore. That's how I like to think of it, right? It's like, not that, oh my gosh, we have to take, the middleman is taking all of it. It's like that 2/3 of what we spend is no longer necessary to spend. You could repurpose that money somewhere else.
Right, and technology and medical innovations have made it such that those 2/3 are not necessary to spend.
It's kind of a different take on it. It's not like, oh my God, medical care should be 100%. It's like, well, we're only using 27%. We don't need it. We are more fuel efficient, right? We are more fuel efficient. We don't need to fill our gas tank with the extra 73% anymore. We don't need that. We need to modernize and use technology to streamline it, because at the end of the day, medical care is finite, right? It's finite. Now, part of that 73% is the marketplace of healthcare. That we have very little control over. That's where the drug companies can decide a generic drug can be really high priced or low priced, and they're going to just set their margin, because that has to do with the way business is practiced these days, right? Forced obsolescence of technology, so that you buy another phone or you buy something else, right? We know that there's business practices that are designed in a boardroom to make money, right? To make a margin. When it comes to medicine, that's hard to sell. It's just not something people want to digest, right? You don't want to pay an exorbitant amount for this miracle drug that's saving your life and say, well, we can save your life, but now the price is up to $200,000. Now it's $300,000. Now it's $400,000, right? It's like prices for medication should not be set supply and demand. And they certainly should not be manipulated by middlemen. So that's that 73%, right? So if the healthcare dollar, which is heavily subsidized by the government, continues to pour money into the system, they can stop the flow of cash to that 73%. They can say, we don't need to keep that lights on in that building anymore, right? We don't need to keep the electricity on. We don't need to, keep the air conditioning going 24/7, right? We don't need to waste all of these resources, right? We can shut all that down. And that's where the government comes in, because 50% of the healthcare, of the federal budget, goes to healthcare in one way or another, either directly through Medicare or Medicaid, or indirectly through Federal Blue Cross to their employees, or paying for TRICARE for their military, right? 50% of the federal budget is going to healthcare, and a full 73% of that goes to middlemen. That means 1 out of 3 of our tax dollars is fueling these inefficiencies. We can vote on that and say we don't want that. We do not want. We take that extra tax dollar and put it somewhere else. But don't put it there. And that's where the government can come in. Government doesn't do well with healthcare in general, but government does well for consumer protections. And we are the consumer. And as soon as they recognize the patients are the consumers, put in consumer protection laws for us.
Yeah, that makes a lot of sense.
And protect our privacy, our data along the way.
Yes, right, exactly. A lot of bad actors in the ecosystem, and for the. Mm-hmm.
Yes, but again, you don't take down a system. You create an alternative, and you let the market force drive it. Because ultimately, there'll be a hybrid. You cannot eliminate insurance. You need insurance. Insurance is important, and it's especially important for your health. You do not eliminate it. You just bolt into it a direct pay model in addition, where some of the small stuff you pay out of pocket and the big stuff you get covered. And that's fair. Pay all the small stuff means when you go to the hospital, there's no deductible. Right? When you need that cancer therapy, you get it. There shouldn't be an argument. But the small stuff, sure. Go to your doctor, pay a few $100s, right? Go to that ear specialist, right? There's stuff that we can afford to pay out of pocket, and that's how countries that are like socialized medicine work. And for poor people, give them a voucher. Give them healthcare vouchers. Why does subsidized Obamacare has to be all 100% through an insurance managed care model? Do we really need all these managers? I would argue
73% worth. Right.
73% worth, and it is a system. But think of all the money that we would save. So at the end of the day, do doctors need to be paid more, or hospitals need to be reimbursed more? No, we need to lower our overhead. Eliminate all of these, because every middleman is taking a piece that requires us to give them data for, right? We have to take steps in the way. If we knew we could eliminate a lot of our cost of getting paid, we wouldn't have to raise our fees, because basically, what does it matter? It's a margin.
Yep. Paula, last question. We've talked a lot around the business models of healthcare and how direct pay can evolve to be this alternative model. What other advances do you really want to see in the next 10 years, besides having these alternative models and, best technology and treatment win?
So I would like to see the participation of putting the patient in the center of their care. I'd like to see protection over patient's choice, not just women's choice, patient choice, over everything from, vaccinating your child to, turning down life-saving therapy for an elderly parent. I think that choice in health is vital to protect. I'd like to see a doctor-patient relationship elevate to the point of an attorney-client privilege, where what happens is private and no one can ask a question about it, so that you can have a million laws on the books, but you can't reinforce any of them. I think that the restoring the doctor-patient equation is really important to do, protecting privacy and rewarding transparency by rewarding the patient. I think patients need to be part of this equation. They need to be incentivized, and I think that they're, again, when they say, well, patients need skin in the game, the patients have more than skin in the game. They have their bodies in the game. Again, medicine is beautiful right now and could be so amazing. My residents are brilliant. They train forever. Their technology is, again, breathtaking. The talent that's out there is amazing, especially when you combine it with technology and AI. There are so many answers to so many problems we get so quickly. But all of this is hidden behind a screen. It's a smoke screen at this point. We can't access it. And so to take down that screen, we have to make the system transparent, so that we can know if a study is good or bad, who's behind it, things like that, because again, we do a lot of good things in medicine. We were the leaders in the world in medicine. We're now number 37, right behind Bahrain, but we're ahead of Cuba, which is unbelievable that we have fallen that far, right? Or maybe the other countries have gotten that much better. Maybe I'm not giving enough credit, but.
Gosh, it is unbelievable. And yeah, I mean, speaking of unbelievable, when we first spoke, yeah, I mean, I had heard some, so many different viewpoints around business models in healthcare and value-based care, and what does patient-centric mean? What is valuable? And I have to say that you've been one of the first people I've spoken to has authentically, in the past 6 months or year, convinced me otherwise, right, of what I was thinking, and kind of changed my mind on some things. And I really appreciate that, how compelling and, of course, experience driven, you've been. And Paula, in general, I want to thank you for your time today, your contributions to advancing U.S. healthcare, and your advocacy for many groups you represent, whether it's patients, providers, or entrepreneurs or women. And I think you're amazing, and appreciate the learning and sharing.
You're being way too nice. But thank you. And I do appreciate that. Like I said, at the end of the day, I always think, again, my dad, just take good care of the patient. It's not that hard. And I say this a lot, like it's not that complicated. And they look at me like, oh, you don't understand. It's like, I understand. What is it that I don't understand? And like I said, simplicity is always the best answer. Sometimes the simplest answers are the ones that resonate.
Right. Occam's razor. Simplest explanation wins. Yeah.
The simplest explanation wins.
Okay. Well, thank you again, Paula. Have a wonderful day. And I hope this is the first of several conversations we'll have over time.
Terrific. Thank you.
All right. Thank you.
Thanks for listening to this podcast and being a part of this movement. This podcast is brought to you by Persimmon Health, an offering by Leapfrog Technology that's purpose-built to help innovators imagine, build, and scale digital health products. We're passionate about fixing healthcare and have worked on over 50 digital health products. If you want to share your story or want to work together, please shoot an email to hello@persimmonhealth.com. Thank you once again, and I look forward to seeing you on the next podcast.